The big question is dyslipidemia, which is high cholesterol levels. Everybody in the whole world, including India, where everybody knows that high cholesterol level is bad for heart. Why? Because it can lead to faster deposition of cholesterols or faster atherosclerosis, and which can lead to angina or acute myocardial infarction, which is heart attack. So lowering the cholesterol level has become a target for many patients for prevention of primary heart disease, and also in those patients who have already got a heart disease, to prevent a second heart attack or further cholesterol deposition in the coronary arteries, even post angioplasty. So we have been using various methods to control. First of all is dietary. People always say that guidelines from ESC, from ACC, from AHA, that you can try dietary control, strict dietary control by restriction of fats for at least 3 months before you start medicines. But things are now changing. With the new medicines, and which are safer medicines, now we don't wait for 3 months, and it is the discretion of the physician when to start the medicine. Of course, we should know the guidelines that cholesterol level, which includes the total lipids, consists of total cholesterol, it consists of triglycerides, it consists of high density lipoprotein, and it consists of low density lipoprotein, LDL. So whenever we ask for the total lipids, we see that these four mostly, and these four important parameters, they guide us when to start treatment. So normal levels of total cholesterol, I should tell, because this is a lot of misleading from the pathological report. As we follow, total cholesterol should not be more than 150 milligram percentage. Triglyceride again 150. LDL is little debatable. Few studies shows that the patient who does not have any pre-existing heart disease, LDL should not be more than 100. But those patients who have got already existing heart disease, the LDL level should be at least less than 70, and few studies have shown less than 50, and few studies have shown less than 30. That means drastic LDL control. Now coming to HDL, which is considered to be good cholesterol, should be more than 50. So these are there. Total cholesterol less than 150, triglyceride less than 150, LDL less than 100 for non-heart patients, and less than 70 or 30 or 50 in the patient who already have a heart disease or heart attack or angioplasty, and HDL more than 50. To get these targets, it is not easy. Especially the patients who have already existing heart disease, to get LDL less than 70 requires very high dose of statins. Statins are already very well established for control of LDL, total cholesterol, triglyceride. It does not cause too much of increase in HDL, which is a different ball game completely. I'm not talking about HDL, we're talking about LDL, triglycerides and total cholesterol. So when you say unmet clinical needs, that means I think it is more relevant in two scenarios. One is where there is a familial dyslipidemia. Familial means genetically determined very high cholesterol, even in non-cardiac patients. Here the statins sometimes fail, most of the time they fail to get into the targets. And then of course the role of this new salt, which is Bempedoic acid, will come, and I'm sure that this should be added to the statins, which is 180 milligram once a day. Coming on to the second group, which I feel is more important, because the familial dyslipidemia patients are not so common. More common is the patient of high cholesterol who have existing heart disease. That means he already has angina or coronary angiography done, or unstable angina or chronic stable angina or acute MI or acute coronary syndrome. And these numbers of these patients are not less, especially those who are diabetics. Here the stringent criteria of LDL applies less than 70, and I told you that few studies have shown 50 or 30. Statins alone, they cannot bring LDL to that low, because if the LDL is less than 50 or less than 30, you are almost very safe. That means this patient will not have a recurrent acute coronary syndrome.
Correct.
Here the role of Bempedoic acid will come and should be used. Don't wait for 3 months for LDL. You start statins, for example, if you give atorvastatin 20 milligram or 40 milligram of atorvastatin or 40 milligram of rosuvastatin for 3 months and then see. I think The physician should have, because this is a new drug, so the trials are not so many, but my own mind says that don't wait too long. You can start statins plus bempedoic acid in this subcategory of patients. While in those patients who do not have any heart disease, that means you are talking of primary prevention, there I think you can wait for statins to take over. If the statins fail, then only add bempedoic acid. While in those patients who have already existing heart disease, you can start with both the medicines together in order to achieve LDL target less than 70 as fast as possible. I hope you understand where this bempedoic acid will fall shortly.